Hi, What the HealthTech listeners. I'm your host, Rhian Bulmer. This is the podcast where we tackle some of the trending topics, ideas and best practice in health and social care. This week, I'm joined by Simon Geoghegan, who is Head of Clinical Data Reporting Governance Systems at Circle Healthcare. Welcome, Simon.
Thanks for having me.
I've got the whole job title in there.
You did get the whole job title in there, yeah.
As part of the UK's largest independent hospital group, we know Circle prides itself on being both the UK's most patient-focused healthcare organisation and also the most innovative and technologically advanced hospital provider. There are a couple of big awards you've got. And in 2022, you were named Private Hospital Group of the Year and one of the top 25 best companies to work for. So we can't wait to talk to you today. I'm really excited to have you here.
Yeah, it's great to be here. Thank you for having me.
Yeah, there's a lot of awards there. That was a good list to get through.
We've focused a lot on that since we became Circle Health Group.
Yeah.
From the acquisition of BMI Healthcare, it's very much been focused on how can we become a provider of choice, but also an employer of choice as well. So it's a few things that we're really proud of.
I think they're the two really important things because, if your staff are happy, that's great, but being the provider of choice as well. So just, can you explain a bit to our listeners about the scale of Circle Health Group and your role within that and what you do and how you started out there? Yeah,
so I've been with Circle for 13 years. Started when it was BMI Healthcare. Seems a long time ago now, and then obviously in the sort of the post-acquisition era since Circle acquired BMI Healthcare and we became Circle Health Group. My role, as you say, is Head of Clinical Data Reporting and Governance Systems, which is a bit of a mouthful. But my role primarily is to look after the governance systems that we've got, from audits to incident management, risk management, and all of these elements, and then the reporting that we can get out of that as an organisation. Working within the clinical services team, but very much having a role that supports health and safety and operations and finance, because whilst we have a big focus on patient safety, which is the right thing to do, governance does touch all of those different areas as well. It's really just supporting all of those functional areas, but also all the hospitals as well, because there's a lot of staff and there's a lot that goes on in our hospitals, and a lot of governance to have within the healthcare industry. So
I can imagine. How many hospitals have you got?
So we've got hospitals ranging from Aberdeen down to Dorset. I always get this wrong. I think it's 51 or 52. I can never quite remember the exact number. But we're in Dorset to Aberdeen, as I say, and we've got hospitals in Scotland, England, Wales. We've got around 8,500 staff. I think we've got the biggest group of consultants that work with us within the independent sector as well. We're quite a big company.
That's massive. I bet you get some miles and travel points.
Yeah. Maybe not so much the travel points, but definitely the travel is. But it's all good. It's really exciting to see, the different hospitals that we have and everything that they're going through. It's quite an exciting time for Circle at the moment with what we're, with our strategy and so on. So it's nice to be able to get to those hospitals and see that, sort of coming to fruition as well. So
and being frontline and seeing the reality of what teams' challenges they face.
Particularly when you're bringing in a governance system like Radar. It's then you can learn from what you can make better, but you can also then start to see the fruits of that labour sort of coming to the fore as well, and how it's helping staff as well.
Yeah.
So it's good to get out and about.
We were just chatting a bit before, and one of the things that's quite important is you've been a Radar customer for how long now?
We started the project about a year ago now.
Right, wow.
So it's already it's a year. We've had the system live since February. When we introduced our audits module at that point. So we wanted to take a modular approach to how we were introducing the system. It's been a year since we've been a customer, and we're in the next week or so we'll hopefully be going live with our events module, which will basically cap off the project, and we'll be able to move to business as usual as then.
It's exciting.
So it's very exciting. It's very busy, but it's exciting as well.
Yeah. So what before Radar, what was the setup? What did you have then for all these different modules and systems?
So before Radar, we were managing a lot of our governance in multiple different systems. From an audits perspective, we were still using Microsoft Excel spreadsheets, which is not ideal when you're across 50-something hospitals.
Not if you have my Excel skills. It'd be
invariably, that leads to people being able to break the Excel spreadsheet. As good as you can make that Excel spreadsheet, it's very easy to break one or corrupt it, or those sorts of things. So, we were working off Excel spreadsheets. We had a separate system where we would capture our actions from an operational perspective. We would have our incident management system, which incorporated risk as well. Which again was another standalone system that didn't talk to anything. So we were really working off a bunch of different individual systems, and that makes it really hard from a training aspect, because our staff who are already busy have got to then learn 1, 2, 3, 4, 5 different systems. And then from a data perspective, and being able to pull that data and sort of triangulate it all makes it really difficult as well, because you're dealing with lots of different systems that have got different nuances and all of these things, and it's it can be quite a challenge to get something meaningful out of multiple different systems.
I was going to say, how long would it take to do one report from cutting and pasting?
Yeah, it can be quite. It was quite onerous at the time.
Yeah. And I suppose being able to get that actually. I know it's a really cliched phrase, but how do you know you're comparing apples with apples? How do you know your data sets are the same?
Yeah, exactly. Yeah. So by moving into one system, that's what we're wanting to achieve, and that's where we can start to understand our risk in the context of our incidents, and vice versa. If we have a risk and we identify that we've had that risk materialising more often, then we've got it all in one system where we can maybe re-establish our risk score as a result of it, because we've got the data there that's telling us straight away.
Yeah.
And then we've got that ability to manage all our actions in one place, whether they've been derived from incidents or risks or audits. But also then having the ability to know that we've got an action that's already ongoing, and we don't have to recreate the wheel every time and create brand new actions every time something happens.
Yeah.
So I think we're starting to see that come to fruition a little bit now that we've got the system in, and a lot of the training we've been doing over the last few months with the events module, I think that's really started to I think it started to become evident of just how the system is works in that sort of way of just bringing all the different modules together.
Yeah, and that's the ultimate aim of the system, to get that total view so you can see exactly what's going on at any point. Yeah. But I think the approach you've taken is that sensible approach, module by module, and I think building blocks.
Yeah, I think it helps primarily with frontline staff, because by the time you release the next module, they've already got a familiarity with Radar and how it works, how they access it. So then when you introduce the next module, it's less daunting for them.
Yeah.
And you'll always have cohorts of staff that didn't necessarily use the first module because it's not within their role, but hopefully then that learning can just be shared within departments or within hospitals as to how to use the system, and quite quickly.
Yeah, and cross-functionally. Imagine. Yeah. So one of the things that is interesting, I think, about Circle is your corporate structures, and having that kind of corporate entity and then individual democratised kind of control within the individual hospitals. Have I described that accurately, would you say?
Yeah, I think so. Yeah, I think a lot of what we've tried to do, especially since becoming Circle Health Group, is just to try and understand what our philosophy is and the values that we want and the culture that we want to bring in. We like to devolve that power to give it to our frontline staff. So we have our philosophy, we have our behaviours and values of and that building that culture, and then we also have our Circle operating system, or COS as we call it, which is the way that we operate, and that's that is there from a patient's perspective more than anything to really give people that empowerment, and for people to be able to champion, I'm not comfortable with this, can we just take a pause and, can we just discuss this before we carry on any further? So it's really about, just trying to give that empowerment to staff, not just from a patient safety perspective, but around anything, but we introduced it primarily from a patient safety perspective, and giving people that opportunity to feel empowered and to feel like they have a voice, regardless of what it is. I think that's really important for us as an organisation. And then, our hospitals, they are their own hospitals as well. We obviously have an overall strategy for what we want to do as an organisation, but then the hospitals can have their own strategy that fits within that as well. So they can still, work as their own entity within that structure as well.
It sounds like the best of both worlds. You the benefits and the economies of scale of being corporate and having that high level overview, but then the ability to be localised and do what's right for the individual areas. Yeah,
and we have a sort of a unified, if you like, governance and assurance framework. So that's how we govern from a clinical perspective, from an operational perspective, and that's a really true ward to board approach in terms of how we escalate issues and learn from the good and the bad.
Yeah.
And we don't want, just because hospital A might be doing something brilliantly, we want hospital B, C and D to learn from that, but also the opposite end of that. If something's gone wrong, we want to be able to share that with all the hospitals as well. So we can all learn from each other, and again, there's that voice where a hospital can feel comfortable escalating an issue that they might need support with, to a national committee or straight to our operating board, and they can hopefully get support that way as well.
That's really good, and a really brave approach to say, actually, we're going to look at what's gone wrong to learn from it.
Yeah. I think it's important to learn from, what's gone wrong. And obviously we've got policies in place around our incident management and complaints management. I think it's a really important way to learn from that. And I think there's a lot of connotations when it comes to, governance systems, that they are what I tend to deem as the bad news system, because it's where your incidents go, it's where your risks live, it's where patients have complained about something.
Yeah.
What I'm keen on doing is, as we develop Radar further, is to look at the other side of that coin. It's okay. Well, what is going right? What can we learn from? If we've got an incident rate of 1%, what's going right? The 99% that we can share with people. And if we have a regulator that wants a report around complaints, we can hopefully supplement that and say, well, we had 20 complaints about clinical care, but actually we had 50 compliments as well. Yeah. And I think it changes the narrative then. And I think that then helps our staff and empowers them to say, it's not all about all the bad stuff. It's also about, the good stuff that happens more often than not as well.
We've got a large international healthcare economy that does just that. They're the two things they're focused on, variance and excellence, and those two things coupled to go, well, these are the two ends of the scale and the spectrum.
Yeah, so it's about learning from the bad, which absolutely we need to do. We've got our policies and processes in place to do that, where we do have those, those incidents. I think part of it as well is also understanding and accepting that we are healthcare organisation and we work in an inherently risky area.
Yeah.
Not to say that any incident's not important, but it's about accepting that and then being able to understand if we've got trends that are going in the wrong direction, and can we learn from those and hopefully be sort of proactive with our approach to that, rather than waiting for something bad to happen and then deal with it.
Yeah.
I think Radar, bringing everything into one place for us, allows us to then hopefully take that next step and trying to bring all of that to fruition in the future.
I think that's super important, and quite a few colleagues would talk about that, the importance of looking at near misses rather than just the bad things that have happened, because that's where your real learning is in what could have happened and what could have been much worse. Yeah,
exactly. And it's like, if you were to look at a never event as an example, obviously a never event should never happen, hence its name. And in a lot of ways, we could have a never event that doesn't relate to any patient harm, but the principle is that the process has failed, and therefore it shouldn't have failed. So you've got away with one to a certain degree, for lack of a better term, at least anyway. But again, it's about learning from that, regardless of whether there was any harm or not, because the consequence could have been so much worse than it was.
Yeah.
It's about learning from those.
So from a cultural point of view, because that's quite a progressive culture in terms of that approach, what have been the barriers in terms of embedding that culture, especially when you're doing it from a corporate standpoint into lots of individual organisations?
Yeah, I think it's just changing that narrative and that, what was the previous culture. and it's always a moving thing. It's always a living, breathing thing, culture, and it's the difficulty is trying to get that living and breathing across 50 different hospitals and all the different corporate functions, and make sure everyone's pulling in the right way when you've got those local stresses and those local scenarios that maybe another hospital's not going, not having and not experiencing, that are then impacting upon that culture. But yeah, I think it's just to keep being consistent with the message that we give out around our philosophy and how we want our people to be able to feel empowered. It's just trying to keep banging that drum about it and just keep singing, that same consistent message, really, that this is us as Circle. This is how we want you to, this is how we want you to feel when you work for us, and we want you to be able to express issues and concerns, but also raise that good stuff. So I think it's just about being consistent across the entire company.
Yeah, and I suppose from frontline users' point of view, specifically, it's seeing is believing. It's all great to have the strategy, but actually, as they feel that come to life.
Yeah, I think from a systems perspective and from a technology perspective, it's about giving them the tools where they don't have to spend half an hour in front of a computer just to log an incident. Yeah. From time to time, I'll talk about nurses wanting to nurse. They don't want to be sat in front of a computer for half an hour trying to figure their way around a system and to do an audit or whatever it might be. So it's about giving them the technology, not just from a governance perspective, but just across the board, so that they can feel like they can actually get out there on the front line. So every minute that they're spent in front of a computer is a minute that they're not spending with a patient. Yeah. And ultimately our nurses, that's why they got into that profession. They want to be there. They want to be engaged with their patients. Ultimately, our patients probably want us to be engaged with them as well, because it has a knock-on effect, not just from a patient safety perspective and PSIRF and all of those sorts of things that are coming in, but also the patient experience element, to know that they've come to an independent private hospital and they're getting that independent private feel and experience. That that's what we want to stand aside. That's what we want us. We want to stand out from the crowd, if you like, when it comes to that experience. So yeah, our tools help us to do that, but our tools only help us to do that if they're set up right. And
I think that's one of the key things. Certainly our product and dev teams are really focused on how do you make that front end interaction as seamless as possible, as simple as possible, and as swift as possible, for exactly that reason. So you're not spending hours just collecting data that you never often can see the output of it. What's the point in collecting it as well? And
I think having gone through the project now and having done that, I think there's been an element of playing that devil's advocate. I think sometimes we can get very excited by the fact that a new system's coming in. It's, oh great, we can capture this and we can capture this and we can capture this. And sometimes it's about playing devil's advocate and saying, okay, are you going to use that data? Yeah. If you're not going to use that data, then that's 5 seconds, 10 seconds, 15 seconds that an individual has to spend in front of that computer. Yeah. And when you're then multiplying that by multiple incidents across multiple staff members, across 50-something hospitals, it will soon add up. So as I say, that sort of goes back to that nurses wanting to nurse element. And so if we're not going to use the data for anything and we don't have any regulatory requirement to capture it, then we should consider whether we are capturing it. We can always make a decision in the future about whether we capture it. But it's like I say, it's about playing devil's advocate sometimes around that.
I think it's super important as well to go from that outcomes first perspective, like actually what is it we want to see, and keep it really neat and simple. And like you say, you can add to it over time rather than starting big and it just expanding. Yeah.
What you don't want to do is start too big and then it either just envelopes, because then you start adding more to it, or you start dwindling it down over time. What you would rather do is go the other way. Yeah. Get people on board, get staff engaged, because the staff engagement with the system then ultimately drives their engagement with incidents, and then we start to learn more about our incidents because they feel more comfortable putting incidents on the system, and that gives us more meaningful information that we can then discuss at our committees and learn from the good, as I say, the good and the bad. But ultimately that doesn't come if people aren't engaged with the system and those sorts of things. And there'll always be pockets of differences across the group, with different hospitals, just because of, as I say, those local scenarios and situations. And and again, that's where we can then learn from. And how is hospital A doing better than hospital B? Not that it's a competition when it comes to patient safety, but it means that again we can just learn from these things.
Yeah, I think that, and I think even just the kind of time saving of having it all in one system must be better than lots of different systems. It is just that.
Yeah, absolutely. Yeah, and as I said before, with us, introducing it as a modular way, you've got that familiarity.
Yeah.
So people already know what to expect when they're in Radar. A lot of the modules look and feel the same, so they're not overawed by what they're seeing. So yeah, I think that's a really important element of it as well.
So when you talk about your culture and your operating model, and I'm thinking specifically a lot of our customers across public, private, care homes are moving towards this corporate kind of structure and this decentralised approach to governance. What would you think are the downfalls, pitfalls that our other colleagues might want to think about when rolling that kind of piece of work out versus the real positives?
That's a good question.
Like where to begin?
Yeah, it's a little bit difficult as to where to begin, to be honest. I think it really just comes down to that. You just got to be consistent with your messaging around how you want your hospitals to. Again, just comes back to that empowerment piece and how you want them to. You would want to have the same things being discussed at all your hospitals, so that everybody is, talking. We've got set agendas when it comes to certain meetings, so that we can be sure that everybody's talking about the right things, and we've got that consistent approach across all our hospitals. So I suppose it's about setting up, boundaries, if you like, and then letting the hospital work within those boundaries, but having those boundaries relatively wide, so that that hospitals aren't feeling constrained by what they can and can't do, and they do have a lot of flexibility, but within the confines of what we've set out as an organisation to be good governance. So yeah, I think it comes back to again that consistent messaging and that empowerment of our staff, which is just really central to everything from our culture and strategy, and like I say, the operating model. So yeah, it's probably just more about making sure you're engaged and getting that consistent message out as to how it best works.
Yeah, I like that phrase best as well, about kind of having boundaries but that are not too strict, so people can have freedom to do what's right for their individual organisation within it. But
yeah, because our hospitals ultimately, they are still individual hospitals that have got their own independent, their own individual competition that's around them.
Yeah.
Some of those hospitals are going to have lots of competition around them, some may not. So, those hospitals still need to work in such a way that, they can make a profit and they can be successful within their own, local area. So it's about not handcuffing them too much.
Yeah.
But also understanding that, governance has to come first and our patient safety has to come first. So as long as you're happy working within those parameters, then, you can operate however you like, in terms of, do you want to take new specialties on? Do you want to do these sorts of procedures and so on? As long as you've got the relevant governance set up around that, then I think, it really comes down to the business plan that our hospital wants to introduce, and making sure that they can do that in a safe way within our, within our governance.
Yeah, and with it, so I suppose it's having that really strong framework that's delivered, that is almost an enabler to let people use it to make their own business decisions of what they put in or how they expand it.
Yeah, and that's what I was saying about the that sort of the boundaries, if you like, that the hospitals can operate in. So as long as they're as long as fundamentally all our hospitals are working to that strategy and within the operating system, then they do have that sort of autonomy, if you like, to make those decisions.
And do you get people involved in the kind of design of those sessions? Do you review that framework? Or? I would probably say it's like an ever-evolving piece, and again, it comes back to the empowering staff. So, if our staff were to feel that framework wasn't working, I would like to think that the culture and so on that has been put in place by
by the operating board downwards is, offers that opportunity for people to say, well, I don't think that's necessarily working. And then we can then understand then whether that's a local thing, why it's not working, or whether it's just not working at scale.
Yeah.
And then it's a living and breathing thing. I think that's the important bit about it, and that it can change over time as as we learn new things or as things happen, we can we've got the ability to change it. But I think it's really important to have it in place, whatever that might look like.
I think that's one of the cool things that I see with you guys that I like. It's that ever evolving. You've used that phrase quite a few times, but it's just, this is what we're doing, but we will constantly review.
We have to, you have to keep up with the things that are going on in the world. Yeah. So, we know that PSIRF is around the corner and needing to, I think it's been described as the biggest change in a decade or a generation in terms of, patient safety. So these are all things that we have to take on board when it comes to evolving the systems. I suppose we're in quite a good position with Radar because we've been able to, whilst it's a lot for our hospitals to take on, we've been able to introduce PSIRF along with a brand new system.
Yeah.
And Radar is effectively the mechanism that delivers PSIRF. So in that, to that end, it really means that hospitals are just having to learn Radar. PSIRF is just a consequence of that. They're not having to learn about flow charts and all these sorts of things because it's already pre-built into Radar. So it's not like we've brought PSIRF into an old system and then 2 months later we replace that system and then people have got to get their heads around that. We've been able to bring both of them in at the same time. So, and again, coming back to that empowerment piece, it's about learning from our staff as to, where can we improve Radar? What dashboards would be better for you? What is it that you discuss at your morning ComCell meetings? What information is useful to you and pertinent to you, and are we collecting it? If we're not collecting it, should we collect it? Working with our frontline staff, because ultimately they're the ones that are using the system day in, day out, and so they're the ones that we need to learn from.
Yeah, I think that's so important. And I think it's kind of I don't know if it's an easy segue or not to start talking about the rollout of Radar, but we're interested to hear, and I think our colleagues will be, your experience of rolling Radar out and how you've gone about that, not just in terms of working with us, but internally, because, it seems everything's well thought out and everything you've done has been planned. So a bit about that plan and, what's worked, what hasn't. Yeah,
so we started about 12 months ago that we started the actual project, and we were very clear at the beginning that we wanted to do this in a modular way. Part of that was based around sort of a prioritisation of, some of the modules that we currently used and their sort of appropriateness or, how good they were or not good, as the case might be in the case of the Excel spreadsheets that I mentioned. So we had a clear plan as to, okay, well, these are the ones that we're going to introduce first. And as I touched on before, it starts to then build a familiarity with those systems. So we started with audits back in February. And then we moved to scheduled tasks in March, which is primarily for our safety alerts module. So where we can respond to MHRA alerts and those that we get from third parties in terms of field safety notices. So our response to those. And then more recently, we moved to the risk register module in September. And in a week or so, we will be moving to the events module.
We should have really waited a couple of weeks to do this podcast, shouldn't we, and got the full.
So the events module is obviously the biggie. And that's why we wanted it to be last. One, because obviously we knew PSIRF was coming and we had to make sure we were aligned with our PSIRF approach. We have the other element that is LFPSC, making sure we're aligned to that. But also it's taking the time to understand, what categories we should have, what those workflows should look like, and that in a module that's as nuanced as it is in incidents, and not just looking at it from a patient safety perspective, but an operational perspective, health and safety, and so on. It's about making sure that we had buy-in and discussions with all of these different functions, and that takes quite a long time to do it. But also we were sort of reassured that by the time we get to that point, there will already be a sort of significant level of familiarity that it's not going to be an onerous or a daunting task for people. So yeah, it will be just over a year for the project when we release events. And then I'm hoping in the new year, that's when we can sort of really kick on with, what should our dashboards look like and how should we be, presenting those. We have a governance and assurance framework which sets out all of our different committees. And I would really like to have those dashboards built around what those committees are and what they should be looking at, whether that's at a hospital level and also a national level. And we've started that design phase, but it's, I suppose, until you actually start to use events and you start to get some real data in the system, it's quite difficult to, I guess, plan and think about what they would look like. So that'll be the next element after that.
So just going back a step to talking about the incidents and that kind of mapping it and planning it, that I think you're right, we see across our estate it's a considerable piece of work, and the power of the workflow engine that you can build all these different workflows to automate everything is it's brilliant. That's the kind of point of Radar, but at the same time, that's quite a lot of effort and work to think about exactly how you want that to work in the system.
It is, yeah. And again, it will be a changing thing. I think, as we learn more about it, I think what we've tried to do is also think about our workflows in the context of all that additional stuff that, happens on the Word documents and Excel documents that we invariably end up attaching to an incident anyway.
Yeah.
So if we're asking someone to go off our current system and fill in a Word document to then attach it to the incident, why are we asking people to do that?
Yeah.
Why don't we just build it as a workflow in Radar and keep it all contained? One, it makes it easier for the staff member, but also two, it means that we've got the data there, so we can report on it and we can, learn from it, and we can just run we can either build a dashboard or we can run a report on that. So yeah, it's sort of an efficiency piece, but also, trying to bring all of these things together in one place. The workflows was certainly a big part to do. I think our project manager Craig said that he had to go and have a lie down after he'd read after our workflow spreadsheet because it was quite a big one. But again, it's around how that works best for us from a PSIRF perspective and our response to what we think PSIRF should look like for us as an organisation, but also then factoring in all those other elements, as I say, from health and safety and so on. So it was quite a mammoth task. I'm sure we won't have it 100% right, because until we start using it on a considerable basis, I'm sure there will be changes. But as I say, that's part of the evolution of the system and learning from it, and where we can identify those efficiencies and changes that we can make. I know that we can just pick up the phone to Radar and we can make those changes and get them scheduled.
I think it's it'd be super interesting to do a piece of work. Some of the stuff we're looking at internally is, we've got all these business case tools and things that show the efficiencies, but actually to take one workflow that's the kind of before Radar Healthcare, going off and getting Word documents and all that, and just monitor how that works in the workflow. It'd be really interesting to see that.
Yeah, I mean, I did put the flow chart in Visio a couple of weeks ago, and it's quite.
Oh, did you? Can I see it?
It's quite a big flow chart.
Yeah.
So, but I think that I've mentioned this in the training. I think the big thing is that we just need to trust that Radar as a system, based upon the workflows we've done, will guide the user through what they need to do. So they don't have to have that flow chart in front of them.
Yeah.
It's there as an aid memoir if they ever want it. But as long as we've selected the incident, let's say a readmission, we know that the workflows that appear from that will be around a readmission.
Yeah.
And also about trying to get that sort of hit rate, if you like, of who that workflow should be assigned to, so that we're, the accuracy of that is correct. And then also linking that with, like the dashboard, and just trying to just get to people and get to users as to what the dashboard is and how it's important. Because if people are working from their dashboards and they're doing these things that appear on their dashboards, then the incident management is actually happening organically through that.
That's such a good way of putting it. Yeah.
That's sort of what we're trying to just impress when we're doing the training, is that everything really stems from the dashboard, and as long as people are on top of that,
you don't need to worry.
Then the incident will take care of itself. Yeah.
I think that's probably a bit of a cultural piece, isn't it? From thinking just from my own point of view, from going to having that, I need to remember to do this, and this, to one, trusting that the system's going to do it for you, and also just working from the outcome piece. That is in itself probably a cultural change.
Yeah, I think it's something that we've not necessarily had from any one system in the past. So I know that now that if I'm on Radar or I'm a user of Radar, I can come to my dashboard and it will automatically say, in the next week, you've got 4 audits that you need to complete. You've got an incident investigation to do and you've got a complaint to acknowledge.
Yeah.
And it's just there in front of me.
Yeah.
Whereas previously, because we were working on an Excel spreadsheet, then I had to go and get that Excel spreadsheet open to understand what I had to do from an audit perspective. I had to go and access a different file to understand.
Find where it was stored.
Yeah.
Remember.
I had to access another file to find out what actions I had for the clinical governance committee the following week. So, just having that one location of absolutely everything that a user has to do is really, I think it's a really invaluable area of the system for our staff.
I'll get in super trouble for this, but a little spoiler coming soon is the ability to have those workflows actually in the system so you can see them visually as part of the system and amend them in the system rather than you having to go and build it elsewhere. And
that would be great.
That would add to your kind of
I would love
reassurance,
that.
I'd be interested to see that Visio one. In fact, it's it's not my skill set at all, but as we go around seeing how the workflows in that kind of format just shows the volume of operations that has to go into this kind of thing. There's so many, as I say, there's so many nuances to it, and it all stems from the type of incident that you're having. So you're going to have certain incidents that require duty of candour to be done, and therefore that's its own workflow. If we have infection, we have to report data to the UKHSA. That's its own workflow. So it's really about just trying to understand everything that goes into incidents, regardless of whether it lived in a previous system or not. And then just trying to understand where we can bring it all into Radar. So we had an opportunity where we could bring PSIRF and LFPSE and all of these ad hoc things together within the workflow, and that's probably why it took so long to build it. But I think we will start to see the fruits of that when it all comes out. But as I say, it will be an ever evolving thing anyway. I think that's it, and I think you've treated it in the way that I always say this: the system's a system. It's 10-20%, I don't know of what you're doing. What you've done is an operational redesign, and then Radar Healthcare is a system that supports that.
And that's what we, from a PSIRF perspective, we've always talked about Radar being the mechanism in which we deliver PSIRF. A lot of PSIRF is around, fundamentally, a lot of PSIRF we do already. We engage with our patients. There's not an incident that happens and we don't go and talk to a patient about it. Radar is now obviously just a mechanism in which we were able to evidence that and take on board these things that PSIRF are suggesting that we do within their framework. So it's been a good opportunity. It's been a headache at times to get it all right, and the testing of it is quite tough because there are so many different eventualities that you can have. But as I say, it's all evolution and how we evolve it for our staff.
I think we need to either get you back on the podcast or maybe we'll do something on LinkedIn or social just to kind of show once it's live so our listeners can see, yes, it's live, it's working.
It's we're in the pilot phase at the moment with 4 sites, and the engagement from those sites has been great. We always pick up things in the pilot phase because that's what they're there for. So it's just about learning from them, trying to understand what we can change before we go live. And then eventually we have to bite the bullet and just go for it and so on. So that's where we're at now.
I think one of the other things I like, you were talking about that, reviewing with the frontline users where they might need advice and guidance as you go through, and being able to build that in and kind of say, right, okay, this bit everyone's kind of getting stuck's not the right phrase, but this is a bump, and we've seen examples in other organisations where the advice and guidance is so good and it's so articulate. It's all there, the tool book along with the tool. So it really is how you bring it to life, which you guys are doing.
And I think from a systems perspective, there's so much that's available within Radar as help that actually we've not had to reinvent the wheel. We have the need help, click here button, which is well, for radar users, they'll know what that button is.
The magic button.
The magic button. I always refer to it as the Microsoft paperclip from back in the day. Well, I refer to
Our
it as
dev teams are going to go mad with you.
I refer to it as something like that, but it's much more articulate than. And then obviously
it's better than the paperclip. We'll go with that.
The knowledge base as well is really good. It's obviously saved me hours of time from having to create videos and user guides, but then on the back of that, it's around making our policies available and these flow charts and so on that are specific to us as an organisation, but not because radar is a system and it works in a certain way, but it's about then the individual elements of how we've set the workflows up, because that's where we can then define the product for what Circle Health Group need. So it's about making that all available to our staff as well.
I know this is tenuous what I'm about to say, but it's almost like you've kind of got that where you guys have got that centralised wherever possible approach, but the localised wherever possible, and that's what we try to do with radar, is get the as much as we can consistent, but still allow you that autonomy to build and do what you need to do, so you're not being given this kind of out of the box square peg round hole tool.
Yeah, and I think we've seen that with some of the dashboards and the analytics, is that there's lots that's available to us, and to me that just gives me a framework rather than potentially using it. I can understand how that is currently set up, and then I can then refine that for how we would want it within Circle Health Group. And it gives me a starting point, if you like, in a lot of ways.
Good. So the last kind of bit about the question about there's just a couple of questions on the implementation around what did you do to try and win people's hearts and minds with this, because it is quite a big scale rollout, and I know you did the modular and standard, but it's even though the end point is going to be really great for people, it's a lot to take when you're doing your day job.
It's I mean, I think they say the only constant is change nowadays. And that's, I think our staff are very aware of that, and I think it helps when the change is for the better as well. Yeah, we don't want to change just for the sake of it. So I think it's been about selling that we are bringing 5 different systems into one. And you're only going to have to learn this one system. You're not going to have to
say it like that. It's a lot.
It's bringing all those systems into one. It's just having that one central place and just selling the benefits of that. And then, as I talked about before, it's also then about selling them. I don't want to say selling them the dream, but then talking about the art of the possible for the future. So where can we start to implement areas of outstanding care and recording from that. Like I say, for me, it's around starting to change that narrative around the bad news system and make it a more holistic governance system, because governance is good and bad. It's bringing all of these things into one place just allows us now to take that step forwards with that. It gives us the platform that we need to be able to work in such a way. Whilst also recognising that incidents need to be managed appropriately in the right way, and we've got our policies and procedures, our governance framework for all of that as well. It's really just, I suppose that's the way that we've been trying to sort of sell the benefits of the system, and then hopefully that then happens naturally through people using it and building that familiarity, like we said before, so that they don't feel daunted when they use the system for the first time in a different module. They're like, oh, it looks the same. It's this is what I expected, basically. And just trying to sort of impress upon them that sort of efficiency element as well, like we talked about. Nurses wanting to nurse, not being sat in front of a computer. So wherever we can demonstrate that and they can actually see that happen, then I think that sort of wins the hearts and minds as well.
Yeah, absolutely. And it'd be so interesting to see when you go live with incidents and see that workflow in a physio, but also see that kind of view from the front line of that difference.
And we've worked really hard over the last few years, really, of building that reporting culture. So we I certainly only envisage that that's going to improve with the use of radar. And obviously it's a new system. We're going to go live. There'll be those teething problems, if you like, when we do go live, which we haven't anticipated, or the pilot didn't uncover because there's so many nuances of incidents. But if we fast forward 6 months, then that's where I'm expecting that we can carry on just building upon that reporting culture that we've already got.
Yeah.
And then being able to use the analytics and the the machine learning and all of those things that come with the analytics to then give us that forward view on things as well.
Yeah, and because there's so much more within the system that can be done, but I think your approach has been so sensible in like, let's do it as building blocks and get it right and embedded first. Yeah,
and we can't really even start to talk about any of the AI and all of those sorts of things really, because we haven't got the system live yet to do any of that with, and even then we probably need 6 months of data minimum before it will even start to interpret some of these things. So we know where we can go with it, and we've got an idea of where we want to go with it. We just need to get the next week or so live, and then we can start to think about 2024 and beyond really in terms of what we want to do.
I think that's really important for the frontline teams as well, in giving them that immediate measurable view of what's going to impact them day to day, because certainly you see with a lot of health tech providers, you see this kind of fatigue come from the frontline teams of, oh no, not another system. Yeah. And what's this one going to do? Oh, it's AI and it's going to do this. And, and you almost can feel that, oh, no, not another system type approach. So going in with actually building the foundations and not just the kind of exciting futuristic stuff. Yeah.
Like I say, it's just, unless you get that engagement with staff and they feel comfortable using that system, then everything else falls flat. Yeah. Because unless you've got staff engagement using the system, you're not going to know about your patient incidents. And without knowing your patient incidents, you're not going to know your trends. So it all comes from the front line anyway. That's why it has to be really quick and easy for people to use. The management side of the system, that's probably where the most nuanced elements come from. But, we have a smaller cohort of people that are involved in that. And we're training them in a slightly different way and making them more, making the training more accessible so that they know all the functionality exists. They know how the action plan works and how you can link an incident to a risk and all of that sort of functionality. I suppose it's also impressing on them that whilst the functionality is there, it doesn't necessarily mean it's required to be used for every single incident.
Yeah.
As well, because sometimes that can feel daunting if you've got lots of functionality, which is great, but then it's just impressing on them. You don't have to spend half an hour to be in here. You don't have to find a link to every single incident. You don't necessarily have to have something on your action plan for this incident, but the functionality is there if you want it and you need it.
I think that's the important bit, knowing that you've got it as a toolbox, but you don't have to use it all, and exactly, people knowing that.
Yeah, exactly.
So I've got two questions just to there's three questions to end with, because there's the HealthTech question, which we'll come to, but I've got two practical questions, because we've sat and chatted all about radar and kind of the nice things, and it's all great and good to hear that the things that we want radar healthcare to be are coming to life within Circle. But it's almost like, can you tell us what we're doing well and what we should keep doing, but also what we need to improve on and how we can continue to be partners to our organisations like yourselves to deliver the best possible service?
I think from my perspective, and we talked about this just before the podcast, is at the procurement stage, there was very much a conversation around being technology partners. And sometimes that can be a bit of a throwaway comment in those procurement phases. But I can already see how that is working, and that relationship that we're being able to build. I think the community is a brilliant thing that Radar have introduced. So it's not just about me learning from Radar and Radar learning from Circle. It's about how can Circle learn from other Radar customers and vice versa. Because at the end of the day, it's all about patient safety, regardless of whether you're in an NHS trust or a private independent hospital. It's about what can we do for the best of our patients and our staff. So I think that they're really key elements. I think the the support that we've had from a project perspective, but also like customer success and so on has been really good as well. So yeah, I can certainly see how that partnership's sort of coming to fruition, which is great, and that's reassuring for me for the future. And yeah, so yeah, I would say that they're the two main elements outside of the system. Obviously, from a systems perspective, we've touched on bits of it already, but in terms of the familiarity with the system and the resource that's available, I think it just takes away that, as I say, that daunting prospect of using a system, particularly on a system like Radar, where it's you might have a scrub nurse in theatres that uses the system once every 6 months, and therefore rather than them having to remember, oh God, how do I use Radar? You've got that knowledge base and you've got that walkthrough wizard that will take you through step by step. So I think they are the really good things. I think that are really supporting us, and we look forward to carrying on in the future.
Absolutely. Go on. What about what can we do better?
I was trying. I think I was.
It's like really put me on the spot. Broadcast to everyone, but
I think for me, it's. I suppose it's from. I'm probably being a bit biased here as a system admin user of the system. I suppose it's just making some of those other elements available for me to make, and we've already touched on it with workflows and being able to change those things. I think there's certain elements that Radar could potentially make available to those systems admins so that they can manage it internally. I think it takes a little bit of pressure off you guys from having to support your customers, and as long as your system admins are comfortable with making those changes, I think that would be a really good thing to do. But I think that's probably about it, to be honest.
No, it's an interesting point, because historically it was always kind of that we'll work in partnership to do it, but I suppose part of the partnership is actually working out whether you want that autonomy yourself or not, and again giving the framework within it. So.
I think there is risk associated with that as well, because your systems admins, I'm still learning the system just like our staff are. So it's about making sure that there is a certain competency around that, because otherwise Radar then have to go in and unpick everything that's been done. But I think if you've got that confidence and reassurance that that systems admin is competent, for lack of a better term, then I think that'd be a really good thing. And just certain things like being able to sort of have that autonomy around emails that get sent out and so on. So I think there's a couple of things that we could look at working together on there.
So maybe I know there's some stuff coming up in Dev that answers some of those questions that I'll get in trouble for talking about, because without deadlines and things, but there's maybe something we can take offline and pick up with the wider team about how we could do that. And do that quickly for you.
I am nitpicking there a little bit. So.
No, because it's the only way we learn, and we're a growing organisation, and we want to make sure, we can have ideas about how we want to do things, but unless we consult with you guys, it's...
And that comes back to that community element as well, and, just engaging with other customers and customers talking to customers and so on. But I think once we've got the events module live, I think it's... it gives us that platform, as I say, to start thinking about how we want Radar to work for Circle Health Group in 2024. Onwards.
It's exciting.
So it's very, very exciting. I've got an idea of where I would like to take it and be able to present that to our board and work to that strategy. And we've got a really exciting digital transformation project going on at the moment that we can look to get involved in as well. Again, coming back to that efficiency piece, wherever we can get Radar talking to our other systems so that someone's not having to jump from one system to the other. I think again it just comes back to that efficiency piece and making it easier for our users. So
and there's a few things that we can look at offline around the API adapter at front end and at the reporting end, and how we feed in and build that picture out. So yeah, that is exciting.
I'm looking forward to it.
I think there's probably 2 follow-ups for our listeners. One is we definitely, this is a note to self, need to put something out in LinkedIn in the next couple of weeks once you're live and look at what that event and incident looks like. But we probably need to revisit this in 2024 to look at what that future plan is and what we're bringing to life next, if you'll come, if you'll be a guest again. So I'm going to kind of come to a conclusion saying thank you for your time, but I'm not allowed to let you go without asking the question of what's your health tech moment, the question we ask all listeners, and we have some all kinds of answers, but have you got one, Sam?
Health tech moment.
It can be anything. It doesn't have to be to do with health tech. It can be, the one thing that really resonates with you in your career.
It's probably going to sound a bit of a cop-out, I suppose, but it's really just...
Are you going to say getting radar healthcare?
I think it's just seeing these things come to fruition and the work that everybody's put into it to see it, to actually start to see it on the shop floor. I think that's the big thing for me, and that's not just from a radar perspective, that's different projects that we've done over the past as well. It's just seeing that constant evolution of systems and how that can impact on your staff for the better. So it sounds like a bit of a cop-out, that, but yeah, I just like to see those things having come to fruition after all the work that so many different functions have played in it, and to actually then see it, it's I think that's pretty beautiful, and I think the fact that you're so methodical and well thought in all of the ways that you approach things to then see that come to life is the whole point of it. Yeah, I think it's just nice to see it sort of bear fruit after a little while. So I think that's probably my health tech moment. Like I say, it feels like a bit of a cop out, but
no, it's not. It's good, and I think that's actually, it's that improvement and that helping to make the difference from all elements. Yeah,
and that, that's what it's about. That quality improvement and continuous improvement.
Yeah.
One of our values at Circle is that better is never, good is never enough, and that's what we need to strive towards. That we can always do better in every area, from a governance system to everything else that we do. It's just about understanding that and being able to, have that empowerment to be able to make those changes.
So Simon, thank you for joining us this week. Thank you to everybody for listening, and tune in next time for another brand new episode. Don't forget to rate and subscribe. And if you have any questions for our guests, please send them to whatthealthtech@radarhealthcare.com.